Hey everyone, this is the Nips and Sips podcast. Featuring me, I'm Dr. Jeremy Boyd, my usual partner in crime, Dr. Brandon Cruz, and today we have a special guest, Dr. Randy Lazicki, who
What's up,
is
guys?
a truly impressive individual. Thank you for coming on there, Randy. Um,
Don't
if
set the
we,
bar
we
too high.
yeah, well, we should start talking about you. So there's the reason why we brought you on board, or we asked you to come on board, and thank you for coming. Randy's expert in instrument-assisted soft tissue mobilizations, and also dry needling. He teaches in his own continuing education company. I should just hold on. Let me present this
Yeah,
entire
he has
great.
probably one of the, if not the best resumes I've seen in quite some time here. Um,
Yeah,
so
can you?
he's done a lot, obviously dedicated to the profession, honing his
Yep.
craft. And Jeremy, I'll let you speak on it because Randy's someone you met via your
Mm-hmm.
fellowship training that you guys are in together, and this is actually Randy's second one. So I
Yeah.
guess I'll just pass it off to Randy, and please, don't be humble. Just kind of give us your track here. I see that you're an ATC first. You have dual board certifications. You went through one fellowship. If you could talk a little bit about that, and then talk about the experience at IAR, and then what led you to teaching, because you've taught quite a few classes, both for yourself and in some educate traditional education platforms.
Yeah, is
Yeah.
everyone
So,
seeing all this action right here? Well, I'm scrolling through. Oh man,
where'd you get that resume from? All right.
I looked at. I was just like, oh, I was like, oh, I gotta check you out. Well, obviously, so met you
Yeah, yeah.
at the IR, and I was just like, all right, let me. I remember his name, and then like wanted to find you, and I put that on Google, good old Google, and this
Yeah.
came
Google
up, and I
does
was
it.
like,
Yeah.
oh shit, this must be the guy, because
Is this
not too
outdated?
many
Do we need
people
to
like this.
update some more?
It's
Uh,
still going. That's the best part.
yeah. So, just a little bit of background, I guess, about myself. So, I actually am from New Jersey. So, I grew up in Vernon, New Jersey.
Oh shit,
So I know
Vernon.
representing up there. So,
That's by
um,
me. Yeah.
and
Yeah,
I don't like the cold, so had to move down to North Carolina, and
smart man.
ended up going to school at Wingate to play soccer, not to really do anything but that, and kind of get a little education along the way. Fell in love with athletic training, and then fell in love with rehab. So I ended up going to Elon for my DPT. And then from there, it's all about, and you guys know this, connections you make and people that you kind of work with, and it ended up kind of getting a good connection with those at Duke Sports Medicine and Duke Athletics. And I moved over there for my first position after I finished up at Elon. Then went into their fellowship and absolutely loved it. It was a pretty significant time commitment, and but I got a great understanding of working in an interdisciplinary team. So it was pretty awesome for me, and I enjoyed it. Got a chance then to go into where I am now within special operations. So I'm a PT, a civilian PT,
Badass.
contracted down there. And I've gotten to work with everybody from the start of the pipeline towards the end, so of SF and civil affairs and psychological operations in the Army. So it's been a really great experience for me. Also working with strength and conditioning coaches and dietitians, it's been great. Um, I did start a educational doctorate, and I just actually finished that. August 7th was my graduation date, so I finished that up.
Congratulations.
It's awesome.
Um,
Is that your
and then
DSC you have? Is
no, it's an EDD,
ED.
so yeah,
Okay.
doctor of education, yeah.
Okay. Good.
So that was a neat process to learn again from other different providers. Learning from a phys ed teacher, learning from a sociologist, learning from a strength coach, kind of how we promote physical activity and how we kind of get people moving again and their perspectives. And then what drove
It's
me
cool.
and how I met Jeremy was moving into the IR fellowship in manual therapy, because I think everybody should probably do some reflection at some point throughout their careers. I do it every 5 years. It's been a good block for me, and I said, hey, I want to get better at manual therapy. So I looked around, tried to find one that fit at least a little bit my philosophy, so I didn't have to change it drastically, but also kind of advance myself a little bit. Here we are.
Gotcha.
Yeah.
That's
Awesome.
awesome.
Real quick, if you can shed some light on maybe the differences between your Duke Sports Fellowship versus the IAR. Like,
Mhm.
was there a big difference? Did you feel for lack of a better term, I don't want this to come off the wrong way, that maybe Duke didn't prepare you for manual therapy? Like, what is the difference? And I would like to know for myself, but I'm sure the audience is curious as well.
Yeah, so the Duke Fellowship's focused on D1 sports. It's a sports fellowship. So, you're spanning the spectrum from acute care to, injury management, rehabilitation afterwards. And you get to work, it's site-based too. So that's a little bit different than IR's model where, I'm obviously working where I am. It's hybrid model. And I wouldn't say it did not prepare me for manual therapy. Obviously, I think we all have, hopefully when we leave school, we have a good complement of that. And I've been to continuing education courses, but there's a difference between kind of going to one Con Ed course and then having a structured approach. And I think that's what a fellowship gives you, is a structured approach to learn. And it's not just about techniques, it's about your clinical reasoning, decision-making, your history taking, your physical exam is really what's gonna drive those techniques. And I think that's what a fellowship really gives you, is that mentorship in clinical reasoning versus just learning new techniques. Yeah. So that's the major differences I see between both fellowships. And
so, if I guess follow-up question, because I get a lot of students and early PTs, and they see, myself or Jeremy's, dual board certifications, orthopedic sports, and maybe this is my bias as well. I think you need to have a foundation in orthopedics to be good at sports, because sports is an extension. At least that's my viewpoint. If you can maybe just share a little bit, a little bit deeper into the sports fellowship. Do you agree, disagree with that? You did the sports fellowship first, and then you're now doing a orthopedic manual therapy. Did you do a residency, by the way, or you just studied?
No, I did not. Yeah, I did not do a residency. Yeah.
Okay. Yeah. So if you could just share on your fellowship experiences, then.
Yeah. So I think, I think that's maybe a good question that students ask, and I think maybe students want to jump right into, maybe I want to get my OCS, I want to get my SCS without, maybe they're getting the letters behind the name without actually going through the process. That's another thing too. But I think obviously everybody has a background in ortho to start with from school. I mean, musculoskeletal classes that we all take. Ortho dives a little bit more into that, and especially when we say fellowships, it's manual therapy based. You have to traditionally look at sports too. The sports teams and athletics are going to be athletic training. So that's really where that's coming from, is, even now today, the predominant makeup of all college sports medicine staff is going to be athletic trainers. And there's going to be some SCSs mixed in there as PTs, but that's really what that's trying to bring to the table, is that athletic training type mentality. And it's a little bit interesting. I mean, if you go back in the history of both professions, we both came up a little bit different. So one profession came up from almost the coach ATC, the coach trainer kind of route, and us as physical therapists came out of hospital-based World War II polio kind of treatment. So they both kind of came, and now there's that merge. We're merged together a little bit in sports.
Yeah, and there's definitely. At least up here, some turf battles, I guess, for lack of a better term. But maybe we'll save that for a different show.
Different day.
I think we're deviating here. But your specialty, not to cut you off here or diminish what you do, because obviously you have a great skill set. But you want to talk about, at least today, IASTM and dry needling. So I guess let's start with IASTM. What's your background in that? You're an instructor for Graston as well. Can you, I guess, talk about the research, the way it should be applied, how you apply it, just things like that, and we'll go from there.
Yeah, open that beer, Jeremy. There you go.
Yeah, I'm waiting.
Yeah, I guess.
This guy.
We just went straight in and totally.
Oh, man.
Yeah, I got
just that. That's how exciting it is.
Yeah, Randy, thanks. Jeremy, talk about your beer. Randy, talk about yours.
Go ahead, Randy. I don't even know what my beer is. Technically, it's a surprise beer.
Surprise beer. I got some SweetWater going coastal, a little IPA with pineapple. I usually don't like fruit in my beer, but this one's not too bad. So it makes me think like I'm at the beach, because I haven't been able to get to the beach all summer.
Very nice. Awesome.
Me, I have a former client of mine. I hung out with him on like a week ago, and we traded some home brews, and he told me what this was, but I get caught up in conversation, so I really have no idea what it is. But Brian Crossland, Big Bri, this is for you, big guy. I'll give my rating once I've had a good couple sips of this bad boy. But
All
it
right.
looks delicious.
Yeah, give us
What's
that
in the
rating.
pimp cup today?
I have my crunk cup back. And my Jeremy, what'd you call it? Goblet something? Anyway. With my Noble Oak bourbon here. So that's what I'm sipping on.
Very nice.
But let's go back. Sorry, we kind of got out of order here. Yeah, Randy, if you could shed some light on the system component here.
Yeah, so my background, I got into treating with instruments when I was at Duke. I had an individual there who was a clinician, and I was like, hey, what's going on over there? I think as an athletic trainer, I used a reflex hammer and something like that, but
Yep.
it was just he was getting effective results with his patients, and I think that's how we kind of pick up on some skills too. Is that you see other clinicians that you're working with, and you're like, well, they're getting their patients better even faster than I am. Well, I need to learn what they're doing. So that's how I kind of got into Graston, and I've been instructing since 2014. Been a lead instructor since 2016. And I enjoy the modality, and I teach it because it works for me, and I like to share. So if I can share my experiences, my backgrounds with it, then I'm absolutely going to do that. Yeah.
Awesome. Jaron, well, first of all, what's your rating there, bud?
I haven't got a good sip. I had
right.
The thing was highly carbonated, so while you guys were talking, there was beer going everywhere. I was trying to keep my cool, but
Randy, what's your, aside from just the fact that you get good outcomes or patients respond, I guess can you shed a little bit insight on just your approach in the clinic, and then also maybe just share some evidence, because I think out there we're getting to a point, with social media and everything that there's two sides of the spectrum. We have people that try and follow research to the letter of the law, and then we have people that just poo-poo it and say it's not applicable, and there's flaws and biases and fraudulent research. So, if you could kind of address both of those questions there.
And then I have a good follow-up question after that.
Yeah, I think just on the topic of research, we can kind of get into this a little bit more with instrument assisted, but physical therapy research and just rehabilitation research is going to be a little bit different than medical surgical procedures or medications, right? Like we're usually just going to do stuff and then research it later. So we kind of do a half backwards pyramid when we're talking about developing case series, clinical trials, all the way up, where we're not going to get a vaccine, or we're not going to get a medication, and we're not going to get a surgical approach unless it's been going through animal studies all the way through. Graston technique and instruments, they started off, depending on where you're thinking, Cyrax cross-fixture massage and adding an instrument to it. So it was just applying principles, and then they start doing research on it to find out, why is somebody getting better? And I think intuitively, we always want to know, right? So I want to know two things. I want to know that somebody's going to get better from my intervention and why they're getting better from my intervention. And the first one I care more about. I care more about what the patient tells me that they're getting better, because if I can get them better, they're going to come through my door, they're going to be happy, I feel happy with myself. On the back end, we want to know why. I mean, we're naturally intuitive as PTs. I mean, I think that's where the research is really lacking, right? We have all these theories of why, but nothing's kind of that single entity that lets us know that exactly what's happening. For instrument assisted, I think it creates a window of opportunity for me. That's what I tell my patients, like, hey, I'm going to create this window. You're going to be moving a little bit better. I need you then to adjunct that with exercise. So it lets me enter into their movement system a little bit faster. It lets me reduce their pain so they can move better. And then exercise is the staple. For me, it's still exercise. I got to give them the correct things to move and to move better and move more often.
That's awesome. That's perfect. That's I think we say that
we've talked about many of those. We've talked about principles versus methods, which you touched upon, as well as the whys. So
window of opportunity.
Yep, window of opportunity.
Yeah, just the evidence. Yeah, go ahead, Jeremy.
No, well, speaking of evidence and that sort of thing, some reason why I was just like, I know I was attracted like, oh, we gotta get Randy on this show. Was I think when we were talking about McMurray's test, and for all our listeners at home, and there's these people that hang their hat on one or two research articles, a lot of them bashing manual therapy. The two gentlemen I'm talking to right now are probably more in depth in the research than I've met of a lot of the PTs I've ever met out there. But I think we're talking about McMurray's test, and you knew exactly the reason why behind why McMurray added like internal rotation, external rotation, the exact how the technique was performed, as if you were actually there in the lab with him working on it. I was like, oh shit. So it's really cool to kind of hear that from you, and I can just hear how you kind of express yourself, how involved you are in the research. So, kind of going off of that. Something that I wanted to bring up was that kind of follow up question was, we had another guest on this, Dr. Kyle Feldman, and he brought up something pretty interesting. Was that he stopped performing manipulations for a period of time, and he's big into manipulations. Was there ever a time frame or anything like that you tempted to try to get the same results that for your patients that you typically would use, instrument assistive techniques, but decide not to, and see if it made a difference at all?
Not I can't say I have, and I think the reason is maybe the setting I'm in. I can't afford to try things out and not get results right away. And I think as long as I understand and I'm comfortable with the theories behind it and kind of what I'm thinking of. I think another thing that maybe we can touch on is a lot of new grads they don't know why they're doing something, so they're taught to do X manipulation for this type of movement dysfunction. Well, really, why are you doing it? What's the theory behind it? Is it just you're closing your eyes and doing it, or what's the really purpose behind it? And I think as long as you have a purpose, you can sell that to the patient, and that might be why they get better. Is you're selling the intervention and you're selling that placebo effect. But again, it's a window of opportunity then, and to get them to move better, to get them to kind of restore their function.
Yeah, I think you said it great. It's what's your why, no matter if it's any technique, and I think and you said it was point number 2 for you. What's the why behind doing this intervention or any other? And I think it's important to understand and do your due diligence as a clinician and understand the different plausible theories that are out there, whether there's one or whether there's 7. Because there's probably some validity to all of them, and now it's your job as a clinician to sift through it and determine which is occurring, or maybe which is occurring for said patient, because it might vary patient to patient. Would you agree or disagree with that?
That's right. Yeah, and I think as long as you have that purpose in mind, then you're going to be a good clinician. Even if your purpose is not exactly as mine, I mean, there's plenty of different ways to get to the same point.
More than one way to skin a cat.
It's true.
Question with IASTM, and I know when I started using IASTM as I was a student, and I was all about learning each technique, because for some reason I thought the techniques were going to make me a better clinician. So that was my initial road path, and then shortly after that, when I graduated and then went to residency, I developed the whys and the clinical decision making and reasoning, and I started to question not only myself but research as well, and just everything. But early on, it was. And this was 2012, 2013. Graston or instrument-assisted soft tissue was create the petechiae, basically bruise your patient, rub them until they start to turn red. I've since backed off on that, but can you shed your expertise on that, your rationale on that? Should we be doing that? Should we not? Is it okay to do it to certain patients and not others? Just what's the theories behind that?
Yeah. So I'll speak from a Graston bias, just from what we instruct, and it's really it's evolution of how we understand we're creating that change, right? So initially our studies were in the animal studies, and those initial studies by Logmani let us know that if we put a heavy amount of pressure down, we get fibroblasts. That's basically what the study told us, right? And it was in rats.
Correct. Yep.
But what we really ignored, and we ignored as instructors too, was, hey, if you put light and moderate pressure down, you also get fibroblasts. So why the heck are we injuring normally healthy tissue when we don't have to, where we actually get clinical results by causing fibroblasts to get there? Maybe we're going to desensitize. So that's number one for me, is we're going to desensitize that system. Maybe their tone's going to be reduced. Then we get fibroblasts there. Now there's evidence to show maybe there's some circulating stem cells that are coming as well. So there's plenty of different things that we're doing without putting heavy pressure down. And now we instruct, and we've since revised our Graston technique, that you are not bruising somebody, you are not causing petechia, because that's not our approach. Our approach is built more off of treating the fascial planes, treating mechanotransduction is kind of the evidence that supports all of that. Where we're putting pressure down mechanically, but we want to have a chemical effect happen in the body. Yep.
I have another question, but Jared, do you have anything to ask or add, or?
No, I comparing to what I got in my most dry needling course for our fellowship for IAR, was how he explained IASTM and different types of soft tissue techniques, but especially like IASTM can improve the the mobility or the sliding effect between muscles, and then we'll talk about dry needling, how it actually makes some actual more plastic changes or causes more of that immune response. But no, it's interesting to hear that approach from Graston.
And even that sliding, we're not exactly sure that's actually happening. Like, I'd be foolish to say you're deforming fascia. Like, I don't know if you're quite doing that, but you're probably bringing in some fibroblasts. You're bringing in some HA into the system. You're causing maybe a more viscous substance to be a little bit more liquid, because you are bringing in some substances. So now maybe the patient can move a little bit better because they're desensitized and they have that extra flow the extra fluid that's in there. When we talk about getting in there and breaking up a scar, that's not happening, and we don't instruct that. Like, that's probably not going to be your mainstay treatment for instruments.
Yeah, I think that's important to just kind of reiterate, is where it takes thousands of pounds of pressure to deform tissue, and probably some of the changes we're making are neurophysiological, or something with descending inhibition affecting the hypertonicity that's there, and we're not actually mashing or breaking up soft tissue or scar tissue, like you said. I did have a question, and I guess maybe philosophies in terms of pressure, to kind of piggyback off your last statement, Randy, in terms of, do you grade different pressures? I know you said, it's doing it lighter, but, there's theories with different pressures, you're stimulating different mechanoreceptors, or different alpha, beta, delta fibers and things like that. I don't know if Graston specifically talks about that, or if you have any research that you point to, or theories, I should say.
Yeah, so there's a little bit of evidence on 2-point discrimination and utilizing a lighter brushing technique over an area. So there is some, and again, we don't know why. We just know 2-point discrimination got better. That's what the study told us, right? So there's different variable techniques that we utilize, and we teach a desensitizing, basically, stroke that's pretty light, works on that light touch, and then we also teach a heavier pressure. Again, not to cause bruising or bleeding, but heavier pressure to get that mechanical force. Mechanotransduction is kind of what we're going for at that point. And that's similar, to you doing exercise, or you going on a foam roller. So there's plenty of different ways that we kind of use that in practice.
And how about in terms of making a hypotonic, quote unquote, muscle, activate more, I guess, for lack of a better term, and having a hypertonic kind of de-inhibit a little bit with speeds? I know that's kind of out there a little bit as well. If you move the bar or tool faster, you're going to excite the muscle, and if you move it slower with deeper pressure, you're going to de-inhibit it. Anything to that?
Yeah, probably likely made up, but theories. It's theory. Okay. It's not. There's no evidence to support it necessarily, but we pull a lot, I think, from massage therapy too, right? So. If a massage therapist is doing a gentler stroke, a more elongated stroke, things are going to take that tone down. If you do a more aggressive sport massage, you're trying to amp things up. So it's kind of that same philosophy pulling through. but there's nothing that shows one's actually causing that change, minus the clinical experience. That's going to be one piece.
Agreed. And I think, would you say some of it is some trial and error, and that's how we develop our clinical decision-making, that clinical experience and, in a good way, clinical bias. I think it's important to have bias, but also be aware of your bias. Would you agree or disagree with tools such as, cupping, IASTM, dry needling, things like that?
Yeah, I think we probably all had a professor in our program that said every patient's an N of 1. Right. So I think I think they send that out in a mass email to all the professors, right? Like every single patient you see is an N of 1. You need to get information from that patient and develop your clinical reasoning off of that patient, but also what the evidence says. And for me, if it's working for the patient and they're getting better and moving better, well, I'm going to keep on doing that same intervention. Even if the evidence says, oh, you should do something else. Well, too bad. This patient's responding to what I'm doing right now. So, I think that's in the back of my mind to develop that clinical expertise. But then you also need to recognize, and maybe some of the bias is that just because it worked with one patient for the same condition or similar condition, don't think it's going to work necessarily for the same condition. You have to be open to other options.
And how long are you willing to give that? Okay, I had somebody come in with, let's say, a rotator cuff tendonitis, tendinopathy, and it worked with Graston, and you get another person come in, I'm going to do the same thing and work for the last person. How long are you letting that ride out before you switch your approach if it's not working?
Yeah, so I mean, if we're talking specifically like tendinosis and tendinopathy, that's a little bit longer treatment. But I definitely expect maybe some desensitization to happen. Like something's going to happen, hopefully, that first visit. If nothing happens that first visit, I'm wondering if it's actually a musculoskeletal condition or not, kind of thing.
Correct.
So, but a couple weeks for tendinosis type condition and kind of working through the phases of rehab. If we're talking more about just movement dysfunction, well, I want an immediate change. I mean, if I'm desensitizing and I'm trying to get them to move better and I can't do it, well, I need to change my technique because I needed them to go home with something. So I might change it immediately to get that change, get that window of opportunity, like I said a couple times.
I got you. And last question before, sorry, Jared, do you have anything? I'm sorry, I'm just like rapping.
No, you're good. You're good. I mean, sounds like you'd probably, how often are you using like the test retest principle, especially with like IASTM and that sort of stuff?
That's 100%. So okay. I follow, I do some SFMA stuff on the front end. So I kind of follow that model and kind of work my way through that. I think intuitively, as we get more experience as clinicians, we're utilizing something that works for us in our patient population. So, whatever you're using for your movement assessment, I've added some things in my movement assessment. I'm going to continue to do that. And then that's my pre-test. I try to find those asterisk signs and then work my treatments and then retest those again.
Awesome.
You had mentioned fascial planes and things like that. There's a big book by Thomas Myers, Anatomy Trains. I know when I was going through, especially my instrument-assisted soft tissue training, and again, this in school. I bought the book. I read it from cover to cover. I think probably twice, at least 1.5 times. In terms of the connecting fascial planes and things like that. Is that something you keep in mind? Do you agree with it? Disagree with it? It was just some. You had mentioned fascial planes. I figured I'd ask. Is this something that you'd recommend people to read just for a different viewpoint or lens to look through things through?
Yeah, it's a good dry read, but you got to be invested in. Maybe only take one plane at a time and really think about it. I kind of like you. It didn't make sense to me as much until I was at Duke and I was working with somebody who ended up having a groin strain, and I finally figured out that was because their neck wasn't rotating. So every time they turned to the right, they couldn't turn to the right, so they had to open up their hips more to get to the right. And it was really, it opened my eyes to regional interdependence. So I think that's really what Anatomy Trains does, is it lets you think outside of just that spot, that segment, and get you to different regions in the body. I don't necessarily think every plantar fascia issue needs to have a suboccipital release. Like that's not necessarily the case. But But don't be surprised if a foot issue is a calf issue, is a hamstring issue, is a low back issue, and you need to go up that chain and kind of assess it at least, and make sure that you're screening those things out.
Yeah, agreed. I don't follow anatomy trains anymore. I went down that rabbit hole. I've since come out. But you hit something important, the regional interdependence, and I think some of the leaders in that, anatomy trains, I would put in there. Greg Cook's movement book, with his FMS and SFMA, were for me paramount. 7 years ago, to at least have that lens and understand that there are other things to look at. Now, my personal treatment approach has differed a little bit, especially away from anatomy trains specifically. But I think that concept of regional interdependence is important to have that understanding and lens when we're treating people.
Yeah, absolutely. Yeah.
Well said. Should we move on to
Dry
needling?
If you have anything else, Jay,
I do have a fun story about IASTM though. I don't know if you guys want to hear it.
Yeah,
please give it up.
So this wasn't me. But this is
it's okay if it was. Was this a friend?
It wasn't.
It was a friend. Asking for a friend.
I was being mentored.
Okay.
This was my mentor working on some. I think we had gouache tools back then. But it was a young guy who he had a gunshot wound from the gun being in his pocket. I don't know how that happened, but
did he cheddar bob himself?
Huh?
Did he cheddar bob himself?
Yeah, I don't know what happened. It was in his pocket.
You ever seen 8 Mile when Cheddar Bob shoots himself in the dick?
No,
You've never seen 8 Mile?
No, dude.
You've never Eminem? Oh my God!
I grew up a sheltered life, dude. Very sheltered, dude. Church every Sunday.
Jeremy, just leave and start watching.
Yeah, I'm just gonna close up here now.
For the audience, you should go watch 8 Mile with Eminem. It was very big in 2000. I'm dating myself.
Well, he shot his junk off?
He shot his pecker, yeah. Anyway, so you had a gunshot wound.
Anyway, but yeah, he had a gunshot wound, and I guess at the time the thought process with using gouache or IASTM was trying to break up scar tissue, because that's what we knew. It made sense. That was our most aggressive soft tissue tool. He had a bunch of it. The bullet fragmented and went to a couple different places. So we're my mentor, and then a couple times with me, because he was showing me, we'd get into the point where some of his scars would actually bleed, like a little bit. That was how much fatigue was kind of coming through. But I forget what happened. Either he was on vacation or my mentor, the treating therapist, was, but he was out for like a week or two. And when he came back, the client, his scar like doubled in size, like his main one. And we're like, what the hell happened? He was just like, well, I was trying to do what you guys were doing. So I'm like, with what? He used like an actual knife, not like your butter knife, like an actual like kitchen knife that you cut a steak with. And he was apparently went to town on himself. Oh yeah. And we're like, oh, that's not what you're gonna do. I mean, that now, if the idea of us like breaking up any scar tissue, you just create a lot more. But it's kind of funny. That's a good show of evolution and growing up as a therapist. But it was kind of funny.
Interesting.
Yeah, I mean, there's a reason why he shot himself in the leg. You can tell by the guy. But yeah,
that was funny. I was. What were you gonna say?
No,
I was gonna say I had a mentor as well during my residency, and I was doing some hours with him, and he legit had a serrated steak knife. And I remember asking him, I was like, do you have a Graston? I had like a fibroblast I would carry around with me. And he's like, yeah, I just use that knife. Just use the non-serrated side. I was like, are you serious? Like, I looked at it, I was like, are you serious? He's like, yeah, it's fine. And then you have this story with this guy used the butcher knife. It's crazy what we do as therapists.
Yeah, pretty nuts.
Anyway, all right, let's. Yeah, that's nuts. I feel bad for that guy. Let's transition to dry needling. So, Randy, you've had some unique training under dry needling, if you can share some of your background, and you've had some of the godfathers there of people who are at least pushing forward, and some of the models that we integrate now. So if you could just highlight that, and then we'll jump into it.
Yeah, absolutely. Yeah. So back in my first experience with dry needling was back in 2009. I was at Duke, and we started a FIFA medical center there. So we had some different players come in and kind of get some treatments or just understand like why they're getting injured. Clinician came down from Virginia and started to do this dry needling technique. I'm like, well, what the heck is this? This is nice. Like, this is a different type of technique. I'm like, can I do that? The next year I signed up for a class, ended up going to it, ended up coming back into North Carolina, and then I figured out that North Carolina didn't let you dry needle. So everybody out there should probably know their scope of practice within their state before they start to kind of go to courses and just think that they can do stuff. But it ended up that next year North Carolina moved to allow dry needling, and I ended up going to the military setting at that point, and they were dry needling for a long time. So I learned my main kind of techniques that I use are off of Chan Gunn's philosophy. So he's up in Canada. He's a pain management physician. He was North America. Him and Dahmer Holt's group were the two main groups, and most I think of Dahmer Holt's group kind of split off in the United States and started to develop some other companies. In the military, one of my colleagues started to teach dry needling within the military because they tried to bring some big names in and they wanted way too much money. So what the command said was, hey, you go to every single course, come back and teach everybody. So that's what he did. He went out and went to multiple courses and then came on back and started teaching it. And that was back in 2011, 2012. And then I jumped on with them in 2014 and started to bring the gun approach as well to that model. So that's pretty much the background. Some in the military we get a chance to observe and shadow, and I got a lot of good mentorship from a pain management physician that we have within the hospital. So I think even for us as PTs, if you have a chance to go and shadow a doc or a pain management physician to see what their philosophies are, it'll open your eyes to some things that maybe you want to kind of to go in and learn a little bit different techniques for too.
Can you just I guess talk about his philosophy? You say Chan Gun model, but just for our audience, what is the Chan Gun model? I think Jeremy and I know, but
so it's radiculopathic pain or neuropathic pain, and basically the model lets us know that compression of a nerve root, compression near the spine, is going to cause some distal effects. So maybe for the audience, if they can think of a patient that keeps on coming in with Achilles tendon pain, they keep on coming in, you get them better, but then they come in again next, maybe 3 months later, you get them better, they come in again. And well, if you go back and think, well, could it be some sort of low-level radiculopathy that is actually causing some dysfunction down the chain? And that's basically the idea, is that those pain sites are not necessarily the pain source, right? So we need to go back to the source. To my patients, I give a simple analogy. I say, imagine a hose and a spigot that's on the hose bib, and you got a sprinkler that's watering the grass. Well, everybody else has been treating you back at the sprinkler at the grass for the water not working. I'm going back up to the hose bib where the trash can is kind of compressing that hose a little bit, or there's a cinder block that's on it. So I need to go back and I need to treat at the source of that issue. And then it's not for everybody. So I think you need to have a good assessment approach to decide who it's going to be before. But, for myself, about 10 to 20% of the population is going to fall in that model, that they've gone through some previous low back issues, some previous radiculopathy, some spondylosis, spondylolisthesis that's causing some sort of dysfunction up at their spine that we can go back and treat. And then the other chunk is going to be, primary, secondary trigger points. It's kind of that bigger chunk.
And when you said trigger points, are you using trigger point, I guess, treatment where you're pistoning or pecking the area? Are you using stim? Are you doing in situ? What's your philosophy on that? Or maybe not a philosophy, but how do you treat?
Yeah, I think all philosophies are actually pretty good because it's all patient tolerance, really. So as long as you get the change in the tissue and change in the movement, that's why when Jeremy said test, retest, if they're on the table and I do just an in situ, and they're not getting a change, well, I need to get them back on the table, and maybe I need to piston that muscle. Maybe I need to add some E-stim into that muscle. My primary go-to is going to be a piston, try to get 1 or 2 twitch responses, and then reassess. That's going to be my primary, but we need to be flexible off of that. We need to make sure that the sensitive patient needs to maybe have a technique that's less aggressive, and maybe somebody who needs a little bit more, or if we want to facilitate a muscle, we need to have that in the tool bag as well.
You had said, I just want to try tying some things together. You use the SFMA. You still currently use SFMA, at least for certain populations?
Yeah, so I use the top tier of SFMA.
Okay.
And then I'll break that down. I'll try to do asymmetrical, make sure it's passive versus active. So, and then I add in a few other kind of screening tests. So I check cross arm adduction. I check wrist extension a lot because I have a lot of guys who do push-ups. So that's a primary prevention. And then closed chain dorsiflexion, I test as well, because it's so prevalent in my population that I kind of add in a few other screening tests. So I use it as a screen to guide my examination of where I'm going.
I'm blanking on the name right now, the company, but they were big on using the SFMA with their trigger point model and then using as a test. They've since moved away from it and now kind of use the STIM model. I'm totally blanking out right now. It'll come to me.
So Kineticore? Or?
Kineticore, there you go. Yeah, thank you.
Yeah.
I don't know why I was blanking on that, but yeah. So,
and I think they since changed. I think they since changed to EIM, or did they move?
Yeah, kind of.
Merged.
They've merged. But they're still Kineticore. I know we took them through my fellowship. They don't use that model anymore with the SFMA. It was something I had asked. And they actually moved away from trigger pointing, and they use more STIM, especially with a handheld and not like the overall. But they have different levels and stuff. But I just wanted to tie that because I know you said you use SFMA. Is that something you use with your patients where you'll test a top tier and get maybe a painful dysfunctional movement pattern and then trigger point? And I know when we were talking previously where you kind of use it to wake up a muscle or kind of slap a muscle. Can you just talk about that and maybe how you use it?
Yeah, so I utilize the SFMA as a screen. So I'll go back to that example of plantar fasciitis and fasciosis and maybe treating the neck, right? Like if they are coming in for a plantar foot pain and they have some neck flexion issues, like that might ring a bell to me. Like maybe I got something that's going on and let me work my way down. Rotation, extension, flexion, the lumbar spine, making sure I add in side bendings. There's a few different add-ins I do. If I had to actually describe what I do, it's probably a celiac scanning exam with the SFMA. That's probably exactly what I'm doing to see if I'm getting some contractile elements and stretch elements that are kind of causing some of that. And that lets me know that it's musculoskeletal. I can dive in a little bit deeper to it. And in regards to like the activation, I think dry needling can have a pretty profound impact on just like I talked about, slapping a muscle or waking up the muscle, and then driving home some sequencing for exercises. So if we're working on leg extension or abduction, like, okay, let's get the core activation, let's get the glutes to fire, let's get the motion to happen. So, kind of following maybe Hodge's model of core activation and some movement that can kind of precede that. So that's basically what I think of. Now, if somebody doesn't have a really big glute contraction, like, I can wake that up. I got a few ways of doing it. I can do glute squeezes, I can do sequencing, or I can maybe do some dry needling in that glute, and then it kind of facilitates them doing it a little bit more.
Yeah. So something I've kind of come across with, some training. We can't do it in New Jersey, but I've continued to, stay with the research and take courses and stuff. Using dry needling as like a neuromuscular tool, and especially you can probably get it with trigger point, and maybe you can attest to it. But I've had or seen results with like stim it high, stim it hard, get that contractile unit, get all those motor units going, and getting it in a more rhythmical approach. And Jeremy, I kind of want to ask you a question too. You just took dry needling too. What's your approach been? I know you guys, I think you guys were in the same class. Maybe you guys can just talk about, what they're teaching you over IAR as well. So kind of two-parter question. If Randy, you could lead us out.
Yeah, I think we need to get input to the brain. So however you're getting that input to the brain, we need to get it there. And then the brain needs to realize it can do it for itself. So
Yep.
absolutely, if you can get that contraction, I mean, that's why Russian was so prevalent back in the day, and still, some forms of that are used now, is to just get input to the brain. But then I think the thing that we can't leave out is adjunctive exercise. All the evidence that's out there: manual therapy plus exercise, instrument assisted plus exercise, dry needling plus exercise. You got to make sure you have that adjunct.
Agreed.
Yeah.
Well said.
Yeah, so I obviously don't have too much experience in the matter. Been reading it a lot more since I've taken that course. I do like IR. It kind of blends the trigger point model, the neurophysiological model. It blends all the models together, which I appreciated. I haven't got to play around with it too much besides on my staff members and a couple of close friends. But what Randy was saying, I work in a sports population, and like especially like runners and those sort of things with those kind of sleepy glutes that just tried a bunch of things, and I kind of found some benefit with BFR of late. But once I started going to that course of like, shit, I really wish I can use dry needling to kind of stimulate these, or as you guys would say, like slap these muscles to kind of wake them up. And I kind of like appreciate, as we talked about in previous episodes, more kind of season I get, the more kind of proximal I'm going. So that neurophysiological model, kind of treating it more proximally towards the spine. I think Randy brought up a good analogy. I brought it up a couple times, and it's just like treating a king toes. You're working with a king toes. You're trying to water your lawn, where I'm just trying to unkink your hose a little bit. I like Randy's version more with the cinder blocks and all that sort of stuff. Spigot, that's a little more in depth, and I think patients will pick up on a little bit better. But yeah, it's kind of where I'm at currently. I really hope that we can practice it more than because I only have 2 staff members, and they're gonna get really tired of me dry needling them all the time. So my wife's definitely not volunteering for that one.
Yeah, evidence is really emergent. So if you look back and at even the CPGs that came out previously, and we talked about this, that the plantar fascia or heel pain CPG in 2008 did not mention dry needling whatsoever, because there were no studies. And then in 2014 there was one study, so that was actually beneficial. It found it was beneficial to treat the quadratus, the flexor hallucis, and flexor brevis and abductor hallucis. But they said, well, it's only one study, so we can't actually be for it, right? I guarantee that the next CPG for heel pain is going to add it in there, because I've already read 5 clinical trials that say dry needling in multiple forms, so adding in E-stem and the trigger point model, have been beneficial for those with heel pain. And if you look back at the recent CPG for plantar patellofemoral pain, they flat out said dry needling is not beneficial for patellofemoral pain. But if you look at what the studies did, the studies treated the VMO and the vastus lateralis. For me, if I'm going to treat the knee, I'm not going to treat just the patellofemoral joint. I'm going to go up the chain. I'm going to treat the hip, the back. I'm going to go down the chain. I'm going to treat the ankle. So I think our forms of dry needling clinically don't necessarily match up to the clinical trials yet. So we're kind of building that evidence as we go. And that's what happens. That's how we started off this conversation, is, PTs and sports, and non-invasive stuff. We're going to do the techniques first, see that it works and keep doing it, and then get the evidence later, versus medicine's going to do the studies first to then give you the medicine. So a little backwards how we do it.
No, I thank you for bringing that point up. I think there are a lot of flaws in what we do. Like you said, the article, and this doesn't just apply to dry needling. Patellofemoral pain syndrome is a pretty big umbrella or a garbage term that just non-specific knee pain gets lumped into. And we're over here saying that dry needling doesn't work because of one study, and that study looked at dry needling one specific muscle. However, we know there are a lot of referral patterns, whether it's from the lumbar spine, the hip, glute muscles, quad muscles that refer, or even hip flexors that refer down to the knee and can give that knee pain. So how do we know? And I think it's important for the audience to know, just because that article says it's not effective, well, maybe they didn't address the right structures. And I have an article that I don't like, and it's a high quality, high evidence article, being the systematic review of meta-analysis by Gaddy in 2017 that looks at dry needling. I think there's like 8 or 12 different diagnoses, from post-op shoulder to plantar fasciitis to knee pain. And in each study, a different form of dry needling or a different structure was targeted. I mean, to me, that's not high quality evidence. You're just taking a hodgepodge and trying to take, people with different diagnoses and lumping them up into a homogenous group, and that's just not how we treat. So I think your example was great, and thanks for sharing that.
When we look at the evidence, for dry needling, we can probably hang our hat on within 4 weeks, dry needling is going to reduce pain. Like, we got that. So that's good for me, because if I can reduce somebody's pain in 4 weeks, well, I can get them moving again. So I'm going to use it as an adjunct. But if somebody doesn't like dry needling, I have other options. There are other things you can do besides that. You're in New Jersey. You guys are excellent clinicians. You're getting your patients better, right? Like, and you're not dry needling. Well, that's your model, and that's how you're treating. You're going to be successful. It's not like I'm down here in North Carolina getting everybody better 4 weeks faster than you. It's you guys are getting people at the same rate because of your clinical reasoning and choosing what techniques meet the patient's needs. Yeah.
Mm-hmm.
Oh, trust me, I wish I could dry needle on vacation.
Yeah. Yeah, there are certain cases where, like, we will get them better, but could have been better in one quicker session or such and so forth. Speaking
I have always said that it's a lot easier to needle for 30 seconds than to do like a 5-minute soft tissue treatment to try to get the same result, right? So
exactly. Yeah. Speaking of research, so I do have dry needles, so just again, play around and practice with them. But if you get iDry needle, which I think was referred to by Toko in our fellowship, they so nicely put all this research for your disposal on just about anything dry needling. So really, really good resource. It's free. I think maybe if you buy something from them, I don't know, but they send it to me. I've been starting to dive into it since I think they released this last week or this week. So real good resources. And again, we're talking about hundreds of articles supporting dry needling here.
And then one thing we actually haven't talked about, which is a different model, which I started to get into a couple of years ago, was, well, can we use a dry needle like they would with Prolo? Can we actually treat in a prolotherapy approach on a tendinosis type condition? And there's one really good study that lets us know we can do that. The rest really use hypodermic needles, but they use it dry, but it's still a hypodermic needle. So it's a little bit different, obviously, it's a lot different than a acupuncture needle going into a tendon. So there's some emerging evidence on that, and there's some emerging evidence on actually treating stroke patients and those with TBIs.
Yep.
So it's going to be expanding every year, and it's going to be interesting to see how people start to incorporate it in more and more.
Yeah, I think a big thing to understand, especially if you're if you're a new grad coming out or a student, and if you've been practicing and you're in a setting, understand if you're in sports and ortho, that not to throw the nervous system or neuro PT upstream, because I think that's where a lot of our effects are coming from, the neuro aspect. And I think over the past probably 3 or 4 years, I've really gained an appreciation of relearning my neuroanatomy and things, the descending pathways, the tracks, the mechanoreceptors. And then if you're in neuro, I think this is a big one. If you're in neuro, understanding that these people still have musculoskeletal symptoms, and if we can, make some changes at those levels, we might be able to do well. And I know there's some studies on neurodynamics and stroke patients or spinal cord injury patients as well. And then for the audience, Randy, I in my head, the article you're talking about is the Minkin one, where he does a tenotomy on the biceps tendon. I don't know if that's the same article. If you were thinking of something else.
It's lateral elbow. I don't have the article on the top of my head, but it's with the tennis elbow.
Okay, same type of deal. They'll use like a tenotomy, poking holes to create that vascularization and things like that.
Fibroblasts and growth factors. And,
understand the physiology basically. Yeah, cool. Awesome.
And I have a maybe a little neat story to add for that.
Please do.
For really getting into that neuro, probably the most impactful time was at my fellowship when the sports doc and myself started to learn ultrasound, so musculoskeletal ultrasound, and he was starting to use it and to try to incorporate some PRP type stuff that was obviously coming around at that time. And the only ultrasound unit that I had access to was in the Peds and Women's Health building. So I had to go to the Peds and Women's Health building to get the ultrasounds, making sure I'm not walking on anything I shouldn't, to learn musculoskeletal ultrasound. And while I was there, I got to talk to the Peds therapist, and learning the neurodevelopmental sequence at that point was the most impactful thing that could ever happen in my career. How I got to spend a good couple weeks with her, how she was treating children. I was like, hey, why aren't we treating adults this way? Because kids just respond to positions. Well, adults can respond to positions too. And that brings in that neurologic model. So PNF, a lot of PNF was done there, rhythmic stave. And that just kind of got me interested in more in that, and really the neurology behind musculoskeletal.
Yeah. And I think for me, that PEDS component, I think something that resonated for me was that it was Greg Cook's book. And a lot of his correctives kind of go back to some of those developmental stages that as an adult we either lose, or maybe because of an injury or pain we lose, things like tall kneeling, half kneeling, crawling, and exercises like that, split stance positions. To me, that was kind of bridged that gap between PEDS, and then later on I connected that neuro aspect back to it. Kind of went from there. But yeah, awesome. Good stuff, man.
Yeah. That's great. So any other last nuggets of wisdom or anything like that in regards to IASTM or dry needling? Any good clinical cases or anything?
I'm out of questions. I feel like I've been pelting Randy with all these questions, but
I felt like I was sitting in Congress here for a second.
Yeah,
so.
I was excited to have you and your experience on there. Thank you for sharing it. Do you have anything else you want to add there, or?
I just make sure that the audience keeps an open mind to all techniques, and really it's not about the technique, it's about your system and how you apply that system and how you apply your examination, and then choosing what technique to do is really and then that my number 2 point, making sure you have a good philosophy behind why you're choosing it.
All great advice.
Well said.
Hey, Randy, thanks again for taking the time out.
Yeah, appreciate it.
Sharing your expertise and your background. Hopefully we can have you on again, and
that'd be awesome.
Perhaps discussing the difference between sports fellowships and manual therapy fellowships, or something else. But we definitely enjoyed having you out.
Or train the tactical athlete. I'm sure you have some real expertise in that. That'd be awesome.
We can get into the PT-HTC debate too a little bit if you want to. So
you hold both. That'd be nice.
That would be cool.
Give you perspectives.
That'd be great. All right. Well, thanks for coming on, and everyone, thank you for listening in. If you have any questions or anything like that, feel free to shoot it at us at Manips and Sips on Facebook, Instagram, and Twitter now. I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursuits PT Now. Randy, I don't know if you have any social media sort of things.
Not really. I got a Facebook page, but we'll just leave it at that. If you want to search me, to search my first name and last name, and you can find me if you want.
Yeah.
You find that stellar CV he has.
Yeah, right. That's
floating around on Google somewhere.
There you go. So, thank you again for having on, and cheers everyone. I'm out. So
cheers, guys. Thanks again, Randy.
Thanks.
Yeah.